We really think this is best done in people that have specialized training to do cardiac CT scans. So it's not a skill that every radiologist will have. It's not a skill that every cardiologist should have. But there are national training guidelines that to do this procedure, and you can do this procedure whether you're a cardiologist or a radiologist, that you should meet those criteria. And we're, in our own institution and really across the services, we will only credential people to do them who meet societal standards to do these, because you have to do this well. You don't want to, folks to get inaccurate results that lead to inappropriate invasive studies and things like that. So there has to be a very good training, and of course that training even extends to the technicians doing the scans. And so, setting up a program is a commitment to excellence. It's a commitment to quality and a commitment to training those involved in the procedures. Well, that's where our clinicians. And so this goes back to the patient, the people that are evaluating the patient at the bedside. And so whether that's an emergency room physician, whether that's an internist or a family physician seeing someone in the clinic who's having symptoms suggestive of heart disease, whether that's obviously a cardiologist or really anyone, they need to understand the strengths and limitations of the various testing options. And of course, many patients don't need any testing at all. I mean, we want to be good stewards of resources, but when you're considering testing, I think you want to understand the strengths and limitations, who's an ideal candidate for which test, and then you have to ask yourself, what's available at my institution? And I know in places where we have made cardiac CT available that it has been a highly utilized but appropriately utilized test for our service members and their beneficiaries. It is absolutely amazing to see where the technology has gone. So when this technology first came out 10 years ago, the biggest criticism was the radiation exposure to patients and the amount of iodinated contrast exposure. And that was a real problem. In fact, what happened over the last 10 years is we've seen the vendors that make the CT scans, the software by which the scans are done and read, has undergone dramatic revolution. In fact, quite frankly, no one was really talking about radiation doses until we started doing cardiac CT scans. And so what's happened is now we are doing CT scans at literally a fraction of the dose. So for example, at Walter Reed, we just installed a brand new state-of-the-art, what's called a dual source CT scanner. And with that scan technology, we are doing radiation doses equivalent to a chest x-ray. If you had told us 10 years ago that you can do a CAT scan of the chest and very accurately read and visualize the heart arteries at that same radiation dose you could do a chest x-ray, we would have never believed it was possible. So these 10 years have really not seen, I think, the technology move away from CT. It's actually made CT more attractive. And what's been nice about that is as the technology has changed to get better heart scan images, that's spilled over into all the other reasons why we image people now. So now at our hospital, if you go to get a scan of your appendix or a scan of your lungs or a scan of your brain, we're going to use the same scanner we use our heart for our hearts. And you're going to get that ultra low dose. And it was really designed to image the heart. And so this has really been a benefit to, quite frankly, the entire field.